the best thing is to give the less diuretics that you can and use CPAP. In some of the cases, I use BPAP, or if you have a anesthetic machine in the cath lab, put the patient on CPAP and do your angiography. This is better than giving only diuretics. And pre-treat with an acid resistate. Okay, we have Mycotis in Mauritius, Mycodine, etc. We can give the patient 2-3 days before and continue after. But the best thing to treat contrast-induced nephropathy is dehydration. This is the one that's going long term to help the patient. So also contrast, apart from nephropathy, can give you other issues. Hemodynamic effects. Remember, when you give contrast, the blood pressure can go down. Electrophysiological effects. You get some arrhythmias. You can get fatal arrhythmias in somebody with occluded LED. Minor reactions, tachycardia, nausea, vomiting. Moderate angioedema, angioedema, etc. So be ready for this happen. And in your court, in your cath lab, there should be the treatment available for this, and your staff should be trained. Okay. Severe reaction do happen. Thrombosis also. Thrombosis of the coronary artery and nephrotoxicity. So to prevent these reactions, you can give cortisone, prednisone, diphenhydramine, antidiuretic tablets, H2 receptor antagonists, and use low glucose molar contrast. For the medical complications like stroke and TIA, it's rare but devastating. What is worse is the patient has come to your cath lab to do an angiography, he is working, he is fine. And then after your procedure, patient goes out with a TIA or a stroke. Okay? For the coronary artery, for example, if somebody has an LED which is occluded, does an anterior wall MI, treated by thrombolysis or by intervention, ejection fraction is 30%. By the treatment we have, patient goes out, he is walking, nobody will tell you, you have not done your job. But if you do an angiography and get a stroke after angiography, then patient will say, okay, this is the doctor's, because the doctor is responsible for what happened. So always be careful in old people. And whenever you aspirate, die, make sure there is no bubbles. One small bubble can make life difficult. Okay? And incidence is about 0.1%, okay? But most of them are asymptomatic because the thrombus or embolus is very small size. So risk factors in which patients will you be very careful. Those with severe coronary artery disease, what in French we call them the polyvascular, those having multi-vessel disease. The length of fluoroscopy time, the longer the patient lies on the table because of the complex procedure, the more the probability of getting stroke. Diabetes, hypertension, or previous history of stroke, or renal failure. Okay? And risk is high in patient with aortic stenosis. So be careful in patient with aortic stenosis whenever you are doing autography or whenever you are doing LV angiography in these patients. Be careful. Luckily for us, we are having good echo machine now, so we don't have to do too much of these LV angiography in these patients to confirm that we have to operate in this case or not. But an autography, in my opinion, is very important for the surgeon, even if we don't do the LV angiography. And the echography gives us very good information. What are the peripheral vascular complications? So we talk about the medical one. Now about peripheral. This one I have told you already. Retroperitoneal hemorrhage, the nightmare of the cardiologist. Those doing femoral. We have in our practice, whenever the many years you do, the more of these cases you get. So I had a case about 80 years old female, acute inferior MI, do angio, cannot do the renal, no access, small vessel, classified vessel, femoral, angio, retroperitoneal hemorrhage. Operated by surgeon, treated, operated, wait, everything, nothing good. There is patient possible. So this happened. Pseudoaneurysm, I told you, AV fistula, I told you, thrombotic occlusion, or this can happen, or perforation of the artery, dissection. And coronary complications is what is more interesting. So we will see about all of them: coronary artery spasms, dissection and Agriclosure, no flow, slow flow, coronary artery perforation, emergency CVD for PCI. So these are the coronary complications. So all the complications have been divided in local access sites, medical, and coronary. So before we go to the treatment, we have to make sure that in your cath lab there is these things, or you have in knowledge of all these things. Okay? In the card, pericardial synthesis strip. In the card, in your table, covered stents, coils and microcatheters for coil delivery, snails, thrombin and or microspheres. How many of them do we have in a cath lab? We are doing cases where we don't have all this. So covered stents we have, pericardial strip we have, coils and microcatheters. I will say we are not very well trained here, but it do helps you to bail out a patient who is getting complication on the table. Snails, there is a different type of snails. We do have some in Mauritius. And thrombin or microspheres we are not using here, but they are available and can be kept in any cath lab. In the room of the cath lab, you must have an anesthetic machine for mechanical circulatory support devices. Anesthesia machine, important, plus mechanical circulatory support devices like ECMO. If a cath lab is going to be difficult cases, the mechanical circulatory support devices should be made available, like IPP, ECMO, etc. ACLS drugs and defibrillators is common, and contract information of individuals providing emergency support or advice is an anesthetist. Okay, it's not when you are doing a case and you are like, oh, where is the anesthetist? And in the hospital, it's good to have cardiothoracic surgery on the premises of the hospital if you are going to do very complicated cases. Okay. Or perfusion steam backup for ECMO. Peripheral vascular specialist, if in case you need to do a aortotomy to go and put a bigger catheter inside the femoral artery. Echocardiography, portable echocardiography should be made available in any cath lab. This is very important. And experienced cardiac ICU care. So if an interventional cardiologist is going to do a complex case where the probability, the risk of getting complications is very high, he should ascertain first that there is a place in the ICU where he is working. It's very important. Sometimes you do a case, you end up with a complication, your patient is intubated, ventilated, but still alive, and you don't have a place to move him. And you have to move him to another center where there is a place. This makes that difficult. And it's a real headache to get place in ICU these times. So, what is, these are the types of algorithm for the management of complications. So, you are doing a case, the patient is in front of you, you're standing, you're working. What do you do next? You suspect complication. You have 60 seconds to decide what to do. Yes, there is a complication. Think, also help or act. These are the three things important. So differential diagnosis, can you do? Who you can call? Enhance cardiac performance, stabilize BP. BP stabilize first, very important. Get the circulation going around. And then decide next what to do. So act, think, also help. Okay? Your patient is stable, yes, continue. Okay, consider what to do or proceed to the treatment. So it's very important to know and to have a logical way of doing things whenever any complication happens. It's only when you go through complication, when you get one, that you decide, oh, I should have done this, I should have done this one first, I should have done the other one first, I should have called the other. So you must always, whether your brain must be working at the time you are doing a case. If this happens, what do I do? Okay. So this is the procedure. Now I will tell you about the coronary complications more, because they are more important. You can get spasm of coronary artery. What type of spasm we have with balloon angioplasty? Intralesional spasm, distal epicardial spasm, microvascular spasm, post-procedural spasm. And there are other Non-balloon devices, IVs, for example, when you put the IVs, the coronary artery, you can get spasms. So the coronary artery is very prone to spasms. So whatever you're putting inside, even a small wire can be spasmed and occlude the artery. So be careful of spasms. And what you do if you have coronary, if you suspect coronary artery spasm, the first thing is nitrates, removal of interventional hardware, calcium antagonist, IV, verapamil, trillium, whatever. Repeat intracoronary verapamil, or repeat balloon dilatation. Sometimes you can do it. You open the balloon again, wait. It can help. Or start systemic circulation, all the blood pressure is high, and bail out with stent. This is where stent was invented, because balloon angioplasty came first, and then stent came as a bailout for unsuccessful balloon angioplasty or for lesion restenosis, and rule out dissection and thrombus. There are many tricks. When is coronary artery spasm common is when we post-dilate. So in my practice, I always give nitrates before I post-dilate, unless the vascular bed, distal vascular bed is very good, or the lesion is very calcified. So I don't think there is too much of fat in the lesion. So I generally always give nitrate. This is one example how you can prevent coronary artery spasm. Now, apart from spasm in the coronary artery, we can have dissection and Agriclosure. There is Agriclosure, there is imminent closure. You see the slow flow in the artery. So you know from your practice that this can close. Threatened closure. So you have to learn about incidence and timing of Agriclosure. So whenever you are doing a case, you must always suspect that this case can give you an Agriclosure. So be ready to it. In my practice, what I do, whenever I'm going to do a lesion, I put the wire in a lesion which is 95%, I bring my balloon near to the coronary artery, and then I put my wire. So in case there is acute thrombosis because of the 0.014 wire, my balloon is already near, and I won't have to waste time. So this helps you to go quicker and prevent the complication. Okay. So causes of Agriclosure, dissection, we are going to elaborate a bit later, spinal microsurgery, elastic recoil of the balloon dilatation, and thrombus. So remember in acute myocardial infarction, in primary PCI, the thrombus burden is very important to decide, so next step how to do. And classification of dissection, you have type A, 0%, type B 3%, type C 10%, type D 30%, and type E 9%, type F 69% of probability of getting Agriclosure. If you have this type of dissection, so you can get the probability of getting Agriclosure in this case of dissection. So let's see what are these types of dissection. These dissections. What I'm going to give to you today is from the National Heart, Lung and Blood Institute, very recognized in USA, and they have described the 6 types of dissections I'm going to tell you now. Type A, dissection, radiolucent areas within the coronary artery during contrast injection, with minimal or no persistence contrast. Type B dissection, parallel tracts or double lumen separated by a radiolucent area during contrast injection with minimal or no persistence. So you see the parallel tracts, but the flow is there, the flow is still going on. Type C dissections appear as contrast outside the coronary lumen with persistence of contrast in the area of the clearance of contrast from the coronary lumen. So there is stagnation of dye in the or around the lumen. Type D dissections represent spiral luminal filling defects, frequently with extensive contrast fading in the vessel. Type E is dissection appears as new persistent filling defects, and type F dissection represents those that lead to total occlusion of the coronary artery without antepocket flow. Okay? So these types of dissections, they have been classified. Why? To help us to know what to do when each organ comes in front of you. Another type of dissection, also I will tell you today, is left main artery dissection. It's very important to know about left main artery dissection, because whenever you're going to do it, your mind is concentrated on opening the artery and putting a stent there. This is your mind. This is what we call oculostereotic reflex. You don't see what's happening around, and it's very important to know what's happening around, because your coronary catheter, the tip of the catheter, the guiding catheter, can damage the ostium of the left main or the mid part of the left main and give you dissection. Because remember, whenever we are doing angio, we are seeing only the lumen. From the lumen, the way it is, we can think about the way the wall is. So whenever you are intubating the left main, we be very careful. And that, for the left main, because now of many cases of left main stenting coming up in the literature, the dissection of the left main is I have shown to you here, is a separate entity itself. Because it is a dissection of the left main and you have not noticed it. You have come out, the patient is still having pain or not having pain. You may lose the patient because of microthrombosis of the left main. So it's very important to know about the types of left main dissection. Type 1 is localized dissection without extension in the LAD circumference. Type 2 left main dissection, extension of left main coronary dissection into the LAD circumference. And type 3 is an extension involving the aortic root. So type 1, there is no high dynamic instability, no in-hospital death, but type 3 dissection, 100% in-hospital mortality. So whenever we are intubating the left main, make sure you are in your coaxium, you are not on a plug, and the tip of the catheter you have chosen, the type of catheter you have chosen is very soft. Some catheters have bright tip, some catheters have very bad tip. Then you have to know the characteristics of the all catheters present in your cath lab. I think the interventional cardiologist must know well about the characteristics of whatever he is using. Okay? There is also another type of what we call catheter-induced coronary dissection. I brought this one here. It's rare but life-threatening complication of coronary angiography. They are caused by catheters, it's called deeper traumatic intubation. Unfortunately for us now, unfortunately I would say, the good catheters are becoming too expensive. And with the COVID era, it's even more expensive. And then we will turn to catheters, especially in the public sector. In the private sector, you can choose your catheter. In the public sector, then you will have to depend on catheters which got through the tender system. And because of many issues linked to the tender system, we will buy catheters which are cheaper, although we know it's not good. And if you are going to use this type of catheters, you have to be very careful. There are many cases of catheter-induced dissection because the quality of the catheter is good. And if there is a case and you are involved, you will never be able to say that the catheter is responsible. The one who is responsible is the interventional cardiologist. The medical council knows this, your OIG will know this, everybody knows the cardiologist. You will not say that no, because of tender you bought a cheap one, that's why I have trouble. No. So the need for cardiac support should be balanced against the risk for iatrogenic. What we call iatrogenic because of the doctor. Sometimes you are very fast, you intubate too fast. Sometimes you go too inside, too deep in the posterior left main. Always respect left main. Okay? So low-grade dissections, they are always stable. In majority patients, timely recognition of and prompt bailout is a feasible option. And female patients are more predisposed to high-grade dissection and have worse outcomes. Okay, so keep this in mind. Okay, so I will show you here one type of dissection. So look at this here. This one here. Okay? So the cardiologist is more interested in doing this. Okay? And then this comes. What will you do? You have to stand. You have no choice. You can't leave it like that and come. And those who are doing cases, if they don't know how to stand the left knee, always ask a senior to come and help you to do the standing here. Okay? Sometimes you look at this, you will say, okay, let's wait and see. You can apply this also, but especially if you don't know how to stand left main, because left main is standing in another world, and it demands another level of working. Otherwise, you will stand the left main and your patient will pass away the next day because of acute thrombosis. Another case, this is the same case after a stent was put in the left main here. And here the patient is okay after some time. Okay, so whoever is doing interventional cardiology must know that left main stenting is not that easy, though it's become more and more common now. But if you are not sure that you can do it, always ask somebody else to help you. Also, this is coronary dissection, iatrogenic. And during the procedure, you can also have aortic dissection. Very rare, but it do happen. There are cases of aortic dissection. Type A aortic dissection, this iatrogenic aortic dissection during percutaneous intervention, very rare. Also, sealing of entry point with a coronary stent is an option to treat localized dissection. More extensive cases may require surgical intervention. Then, if we have the surgeon around, sometimes they can help us to come out of this. So we are going to present a case of type A aortic dissection that occurred during an angioplasty of a chronically occluded right coronary artery. Despite the extent of the dissection, a wash and away strategy was chosen, and repeat imaging a few days later reveals that the aorta has been remodeled to its normal anatomy. I will show you the case now. Yeah. So this is the case. CTO or CA was done. Apparently nothing bad here. And then you see it happens. This is a catheter. The catheter is an XB or AL1. I think it's an AL1. Because of support to the interventional cardiology is an AL1. It's a very dangerous catheter for children that can give you dissection. So you see the staining. Friend. In this case, the interventional cardiology, these are not my cases, okay? I took from the internet and showed to you. So, dye staining in another view. Yeah. Treated medically here because the patient was hemodynamically well. So, what to do when you have a dissection? When you have a dissection, check your wire. If your wire is still around, yes, vessel open, dilate with balloon. If there is no flow, no typically flow, direct to button, put a stent. If you have IVS, you can use IVS to check if everything is okay. If there is a large intramural hematoma, you can use cutting balloon. And always stand the distal edge first for long dissections. Okay. Successful, your procedure is completed. Wire across? No. This is the most difficult part. If there is a guide wire in the true lumen across the dissection, no. Attempt anterogate wiring or spring coil wire. Successful? Yes. All this? Yeah. No. Consider anterogate dissection re-entry. There are some catheters that are meant for this. Or retrograde wiring, if you are good at retrograde CTU. And then subintimal tracking and re-entry. You could use a STAR technique, subintimal tracking and re-entry. Sometimes all these techniques exist. You will not do them every day. You won't get training in them every day. So they must be in your mind. You must see people doing it online. So, and then try to do it. If no, consider CABG. If patient is hemodynamically stable, conservative management, or put an IBP to help you, and then take the patient for CABG. What is bad in dissection, for example, if you are doing an RCA, LAD and circumflex are normal. If there is a dissection in the RCA, your patient should be stable, and it's a big RCA. So you can wait and watch and see. In most of the cases, we'll use wait and watch technique, and the next day you will see, luckily for the cardiologist, the problem is solved. You can repeat an angio later and check. So this is for dissection. So there are many beloved techniques for dissection. We won't go in all of them. You can read about them. This is only to give you an overview what is available. Now we speak about perforation. Perforation is divided into 5 types. 1, 2, 3, 4, 5. Type 1 and 2 are low risk, but one needs to be particularly aware of the risk of progression to type 3. Type 3, 4, 5 are the most serious types of perforation, where expedient treatment is crucial in order to save lives. So dissection in another type of complication, perforation is another one. And this one, you have types of perforation. Type 1, coronary perforation, extraluminal crater without jet extravasation. Type 2, pericardial or myocardial brushing without too much of the extravasation. Type 3, there is active jet extravasation, exit jet, more than 1 millimeter. Type 4 is coronary perforation leaking into another cardiovascular cavity, so maybe the pericardium. And type 4 is distal perforation. Type 5, sorry, distal perforation. So all these types of perforation they do because they do exist. They have been described by many cardiologists who took cases. And there's a nightmare of the cardiologist. If you don't have a drug covered stent, or a covered stent, sorry. If you don't have a covered stent, you may have to send your patient fast to the surgeon. So I will give you one type of type 1 epicardial segment. So you see, there is some extravasation. So the main step of type 1 coronary perforation is to inflate the balloon at the site of perforation. Type 2 perforation is too wide, you won't see it, but so there's a epicardial segment, pericardial, myocardial brushing with one extravasation, slightly here. Right. A type 2 perforation is similar to type 1 in terms of management, but is associated with a higher risk of progression to type 3. When myocardial brushing is considered to be lower risk than pericardial fasting. Okay, type 3 is active jet extravasation. Here it is. After balloon dilatation, see what we get. So type 3 is an exit jet more than 1 millimeter. Here. And type 3 coronary perforation is the most serious perforation, and expedient management is crucial to preserve life. Okay. So after balloon dilatation, the cardiologist has put some dye, see what's happening. Okay. So previously we used to keep the balloon in the guiding catheter just to see in case there is a perforation, you can bring back your balloon, go to higher pressure, press, dilate, and wait for 2-3 minutes till the patient complains of a pain. Okay. But this may help when you take a bigger balloon. Now, if we don't think we will get the perforation, most of the time we remove the balloon and leave it there. So type 4, look at this. So you see these are a post-CABG patient here. perforation do happen. So management is similar to type 3. However, the blood leaks into another cardiovascular cavity of a ventricle or coronary vein. As such, the symptoms are usually that of a new shunt rather than hemodynamic compromise, or due to a new pericardial effusion. So type 4 is better tolerated generally because you're going to another intravascular space. I hope you're seeing it well from there, from the back. So type 5, coronary dissection perforation, maybe initially missed as a leak into the pericardium, is often small and may require panning to the distal vessel to be appreciated. So here you can use embolization of distal vessel with thrombin or coils. So what you do in these cases, with type 1, type 2, type 3, prolonged balloon inflation, more than 10 minutes, 2 to 6 atmospheres. You may take some time a balloon which is slightly bigger. Okay. Type 3, or type 4, no intervention. With type 5, distal guidewire perforation most of the time. So prolonged balloon inflation. If all this doesn't work, consider correction of coagulopathy, blood platelet transfusion. Use covered stent as bailout. Post-dilate covered stent. Sometimes you can use another second covered stent. Coil embolization or surgery. Or in the distal part, you won't send the patient to be operated because of a distal vessel perforation. So you can use fat. Some cardiologists aspirate fat and put it in the coronary artery. Okay. You can use gel foam, laser gel foam, microcoil. Microcoil is available, but we don't have it in all cath lab. The problem is you buy these things and you don't use them. After 2-3 years, they get expired and you don't know what to do with them. You can easily use aspirate subcutaneous tissue and embolize the artery with a subcutaneous tissue. So that's why it's important to know all these techniques. Okay. So I'll show you in a case also, this is one case of perforation of temple dilatation, 60-year-old female, or CA lesion angioplasty. Looks simple. I don't like this place in our CA. When it's calcified here, you are easily into big trouble. One is difficult to get the stent going through this area. See this area here? And this area is where there is the junction between the right atrium and right ventricle. Then you can easily go into perforation here. So balloon dilation for 10 minutes, AP drop, so balloon deflated, check angiography, leak press stent, finally covered stent was 2.8 by 19 millimeter, inflated at 16 atmosphere, okay, and leak seal. Echoes there is minimal pericardial effusion. So it's very important to have a covered stent in the cath lab. Okay. So complications. So remember, our main big teachers how we can improve our skills at the same time and how to bail out the patient. So coronary perforations lead to pericardial component. Managed with prolonged balloon inflation. On the second case, I will show you here. Pericardial synthesis, etc. Reversal of anticoagulation. Patient stabilized and shift to ICU. Next day, check circumflex and the state PCI. You see the case where LED stenting was done. Stenting of the circumflex was done with this type of perforation. You see this type of perforation here? Okay. Right, and then the LED was done. So LED lesion was sent later. So sometimes you have to think out of the blue what to do and how to help your patients. And always keep your mind all around because you don't know what can happen. And you must have covered stent. problem with covalent stent in Mauritius is that the companies don't bring it because the sales are very low and they are quite expensive. So we'll go back again to the case. So perforation here of the balloon dilatation, perforation treated with covalent stent, and then the LED was done. So even if you have perforation, what is the algorithm to do? Is the patient stable? Yes. Obtain surgical echocardiography to assess pericardial diffusion. Tamponade, you have to put a pigtail. Yes. Wire across here. So balloon component of the perforation weight. Use covalent stent. Okay. If no, give intravenously to keep hemodynamic stability. Okay. You can also use autotransfusion. Notify cardiac team, surgery team that maybe we'll send you one patient. So use balloon component again. If no improvement, use coils. No improvement, surgery. Okay. And so if this react fast, you can use your patient. Now speak a bit about no reflow and slow flow. So no reflow is a common complication of patients with non-ST elevation MI or whenever you give these cases of an unstable path. So be careful about it. It's mostly due to epicardial obstruction. Yes, if there is no reflow. Okay. Dissection, I told you. Embolism can be the reason for no reflow. Dissection, one is the reason. Embolism. If you see that there is a dissection, you can do the same algorithm we have done before. Embolism. Okay, give patient 100% inhaled oxygen. Aspirate if you can. Then proximal thrombus, aspiration, balloon angioplasty. So that's why to prevent no reflow, always give nitrates before doing dilatation. Okay, and pharmacological treatment we have for no reflow, adenosine, 100 microgram to Jugessur vessel, verapamil, nicotine, epinephrine, nitroprusside, or intracoronary integrin or Dissection, etc. If resolution, complete case. If no resolution, use IAPP, give diuretics, etc. Improve perfusion and help your patient. So when slow flow or no reflow is encountered of the PCI, vasodilatory agent should to improve epicardial and myocardial flow. After the occurrence of this complication, it should be administered an effort to improve myocardial perfusion. Okay, this will improve prognosis. So always have your nitrates. Nitrates are quite cheap. Before you start the case, get them already prepared on your table. It's not something that, especially when you are going to do a PCI, keep nitrates ready. Slow flow and no reflow of feared complications because of epicardial coronary flow, impaired epicardial coronary flow. So they manifest as a failure of the affected artery to opacify angioplasty. Okay? And if you give the treatment I have shown to you, you can bail out your patient. So this is a way to describe the flow post PTCA. TB0 is no contrast flow beyond the site of occlusion. TB1 is contrast flow beyond the site of occlusion but failing to opacify the entire artery. TB2 is contrast flow beyond the site of occlusion and opacification of the entire artery but the rate slower than normal. And TB3 is normal flow. This is, I brought it just for our young colleagues to know when you are speaking about TB0, 1, 2, 3, what do we mean. Okay. So schemes to describe coronary myocardial. There's also another way of describing coronary artery, the blush technique. Myocardial blush 0, no appearance of blush or contrast density, persistent staining of the myocardium, blush 1, minimal myocardial blush 2, moderate myocardial blush or contrast density, and plus 3. So these are the classifications about myocardial blush. We have spoken of the artery, now we're speaking of the myocardium. There is also classification, obviously, for the myocardium. So in case there is hemodynamic collapse after a complication, what we do? Is there pulse? Yes. Use CPR, assess for etiology of the collapse, and give the treatment as it should happen. Okay. If there is no collapse, you can always find the reason why there is a low BP and improve, give medications, etc. Increase the BP and use the case. Another complication of interventional coronary treatment is device entrapment. So this type of device, guide wire entrapment, microcatheter entrapment, balloon entrapment, and rotable entrapment when you do rotabation. So there are many techniques here. You can use a trapping bunny technique and or snaring to remove the guide wire. Especially when you're doing bifurcation cases, you can get this. Microcatheter, entrapment, cut the shaft and use telescoping system to remove it. You can do balloon angioplasty with another way of doing by balloon angioplasty and snare everything. Or apply strong traction, which can be dangerous. The balloon is cut the shaft and use the telescopic DC. It's a technique, but we use a telescopic DC to remove it. And the burr also can be removed. Okay, but I don't have cases to show you here. There's another technique also. If there is wire loss, this is another complication. What you call is a goose neck to remove the wire. The snare technique. So every cath lab should have a snare. It's very important, and you must know how to use the snare. If you have a snare and you don't know how to use it, there's no reason why you should use snare. Okay. The snare technique is often used for the retrieval in cases of inadvertent loss of the guide wire or stent. Sometimes you have a stent dislodgement from your balloon. Okay. You must know how to try to get inside the stent again and remove it. Of inadvertent loss of the guide wire, but involves several decision and technical steps. We won't go into. It's easier when the fragment is located proximal. Then it's easy for you to see where, and it's easy for you to track it. So example capture will depend on correct alignment of the loop of the guide wire. So whenever we do a case, we see into deep, but we have to think in trick. This will help you to snare out whatever it is. And this is another threefold snare technique, another type of EN snare system from arithmetical. This also can help you to remove wire or remove whatever is stuck inside the artery. So you see there have been progressive decrease in procedural MI and rate of death because the techniques of PCI has improved and there are dedicated equipment, good quality equipment, very soft, very easy to use, and the utilization of adjunctive pharmacological therapy like integrating help us a lot in solving these issues. Okay. So conclusion, I will tell you that PCI is common invasive procedure now with relatively low complication rate, fortunately for us and for the patients. However, when complications do occur, you must know how to come out, how to manage them, and uncertainty about complication management can attribute to the under-treatment of patients with high complexity and high risk coronary disease. So assess your patient well before embarking in any procedure and get ready to do any complication in case they happen. And their management requires preparation, early recognition, diagnosis, knowledge of different techniques available in your cath lab, because you have to know what is there in your cath lab first. You may think about gooseneck. Oh, if I had a gooseneck, I would have come out. But if you don't have to find a solution. Okay. Team-based communication very important. If you have trouble, ask for help. There is no loss of dignity. You ask for help. You ask for help. Sometimes even your cath lab nurse who is helping you can give you an idea how to come out, because he or she has assisted many cardiologists and he will know the techniques maybe better than you think. And whenever when you are doing a case, your mind is focused on this case, so you don't think about anything else. And your staff, even the simple guy, can help you to come out. Strategies and multidisciplinary collaboration important. And the algorithmic approach helps to come out of complications and perform complex PCI. So take home message, I know you are hungry. So from these cases, the lessons are first, it obliges to remember that coronary angiography remains an invasive investigation with rare but life-threatening complications. So indications for diagnostic angiography should be well sound, should be well decided, not any Tom, Dick and Harry to get an angiography. Everybody wants angiography. In some cases, people are just signing the letter for angiography as sending RBS, random blood sugar. So you have to be very careful, check, and then send patient. Second, all catheters must be manipulated cautiously. The catheter is devised in such a way you use it with gentle maneuver techniques. Don't go harsh with the catheter. You end up into trouble, especially when you are engaging the left and coronary artery. And injection should only be made when catheters are properly placed, coaxial, and where there is no ventricularization of the pressures. If your pressure is ventricularized, don't inject time. Third, in the unlucky situation of an atherogenic complication, prompt diagnosis and therapy must be initiated, and most experienced colleague and surgeon should be alerted. Okay, these are the references from where we got all these informations. Thank you for your attention.
Thank you very much, Dr. Jugessur, for the big talk.